Good evening, everyone. We have the privilege of having a master with us, Professor Mandika Chiratna, our teacher. I think both myself and Priscilla was taught by him. Professor Mandika Chiratna is a professor of surgery, and he has obtained his MBBS from Faculty of Medicine, University of Colombo. Then he became to join the university as a lecturer, and he was board certified as a surgeon in general surgery, and went on to his MD thesis in University of Leeds in carotid endarterectomies under Professor Michael Guff, if I remember, and he came to Sri Lanka once, and he was doing uh, carotid endarterectomies under local anesthesia for stroke prevention, and Prof. Mandika took the lead from that and came to stroke prevention in Sri Lanka. Another key contributions as a vascular surgeon, he introduced the color duplex in the extreme distal bypass surgeries and prevention of amputation in Sri Lankan diabetic population. And these procedures are the mainstay of limb saving surgeries today. And he introduced the uh, proximal and distal distal microvascular bypass surgeries for distal limb ischemia, especially in diabetic foot. And management of diabetic foot became completely revolutionized with this management. In parallel, his interest in vascular surgery, he also explaining the horizons of organ transplant in surgery in Sri Lanka. And he started doing uh, kidney transplant first, and then the first liver transplant also conducted under his guidance in Sri Lanka, and in 2010. Uh, so we have a wonderful teacher with us, and so we would like you to
Hello.
introduce. Yes, nice to see you, sir.
Hello. That's that's quite an excessive introduction, I must say, Ranga. Thank you.
So, it is not enough actually to introduce you. Yes, there are more things to say, but it's just a small amount of introduction for you. This is for this group, and coming for this small workshop of us was the great achievement in our college. So I'm warmly welcome you
Thank you.
uh,
Thank you. It's a pleasure.
for this workshop. Thank you, sir. So you can proceed from here, sir. We will continue. Tusita, we have.
I thought Tusita,
Yeah. As an icebreaker, today is supposed to be a question and answer session. So
yeah,
thank you very much for agreeing to do this. Actually, I mean, this is uh, for this batch. Actually, I think this is far too much to ask for. So as an icebreaker, I'm just going to start up with asking this question. Uh, what happens when somebody gets a wound, sir?
yeah. Wounds, getting wounded is a part of life, isn't it? All animals get wounded. Trauma. Life is full of trauma, and we have all the mechanisms to heal ourselves. That's why we are here. Um, Humans, other animals don't need special care, special treatment, drugs to heal. There is a biological healing process which um, is kind of artificially broken down into different phases with a lot of overlap. They move from one to another. And you end up with healing. So if I am to remind you, soon after some injury, there is a break in the tissue continuity, and it's that traumatized tissue is that space is filled up with blood. And the first thing is to stop the bleeding, and you know that there is the coagulation mechanism which kicks in and seals off open vessels with a fibrin mesh in which the cells are trapped. And these cells release certain factors from within, which helps to move into the next phase. So when there is trauma, hemostasis is important. And the next phase is getting ready. Immediately, the tissue gets ready to repair. And how does any repair happen? Firstly, you need to clear up the mess. The trauma causes some dead cells and introduction of microbes from our environment who try to get a hold on the traumatized tissue, and it tries to multiply and basically promote itself. And the host, the injured person, mounts a defense attack, and we call that acute inflammation. Inflammation is characterized by an increase in the blood circulation, bringing in more white cells and other vasoactive molecules to destroy bacteria and lay the foundation for the healing process. So the white cells are very important. It kills and swallows bacteria, and it also removes other dead cells. And in the process, it also leaks out certain chemicals, cytotoxic molecules, which all of it helps to clear up the mess and bring in the cells and the other molecules to start the repair job. And clinically, what we see is gradual cleansing with a little maybe suppuration in an open wound, which is the products of dead cells and dead white cells. And there is some inflammation, redness, warmth, pain in the immediate neighborhood, and
I think there's some technical problem.
Some technical problem here, some disconnection.
Yeah. Sir, you are cut off suddenly.
Hello?
Sir, you are no longer there. You are stuck. You are stuck and cut off suddenly, sir. Yes. While he is rejoining, yeah, he's coming back. So everybody feel free to ask questions.
Hello?
Yes, sir, we can hear you.
From which point did I disappear?
You were talking about redness and inflammation. You can
Okay,
see redness and all that.
right. So the redness signifies a lot of capillaries, and the cells there are the macrophages. The macrophages are also, like white cells, remove dead cells and kill bacteria, and then they change over to becoming fibroblasts. It's a change in the phenotype, and it lays down collagen. So the collagen is the healing tissue, and collagen matures. We call it scar tissue, and you know that the collagen contracts, granulation contracts, even large wounds become thin lines eventually. So much contraction occurs, and that's how we heal. So healing is a natural process. So Tusita, yes, we don't have to. It's as doctors, it's a fortunate thing to have a very good healing process already there, because what I know is that lots of people with minor injuries that would heal in any case come and see doctors, and they're very grateful to the doctors when the wounds have healed, and we all pretend we were the healers. No, biology heals. Where we can make a mess of it is to sabotage the healing process. And there are many ways in which we do that. Not deliberately, but it does happen. Even hospitals, we find all clean wounds. Medical officers are recommending every other day change of dressings. Even sutured wounds, which are sealed off, which don't really need a dressing. Open wounds, if we can only make a mess of things by putting toxic material into the wounds, which will basically sabotage the biological healing process. We'll also put dressings which dry out. Therefore, the healing tissue becomes adherent, gets stuck to the dressing, and if we keep replacing these dressings frequently, we only cause ongoing trauma, repeated trauma. And these are some of the ways in which we actually interfere in a negative way. A healing process which can sort itself out, and the patients would heal, the great majority. So, does anybody have any comments or questions? I was going to answer questions from the audience. Is there anybody wanting to say anything?
So 119, yeah.
Yeah.
119 participants and
Right.
adding, sir. Yeah.
Tusita, you can watch. They might put some questions in the
yeah.
chat.
Yeah, watching, sir. Yeah.
Yeah, then you can ask me. Yeah. So then you might ask, so where do we come in? When a wound is big and the wound is contaminated, we could assist, because when there is a lot of bacteria, debris, dirt, we know that these are going to be the problems to healing. They don't help in the healing. Dead tissue, devitalized skin and fat in extremity wounds. So nature will be slow and struggling to clean up a dirty wound contaminated with a lot of dead tissue. So since we understand the healing process, we could help. I mean, we never heal wounds. Biology, life heals. We can only support, we can only assist. And how can we assist? We can wash the wound, wash in running water. Tap water is more than enough. Our tap water is good quality for drinking. I don't see any issues. I know society and doctors are very frightened of water. And lots of people use saline. The problem with saline is that you have only a limited supply of saline. You don't have saline coming off the tap. And what you need is to actually irrigate a contaminated wound with plenty of flowing, if at all high pressure hose to basically wash out foreign material and bacteria from the wound. So you need to thorough wash, and then if you see loose tissue, it's better to cut them off. It's like neatening the margin of a laceration and get a sharp, clean, nice bleeding edge. Just like that, tissue fragments under the skin also can be removed with a pair of scissors. And then the question comes, how do you close it? Do you close it? If the wound is contaminated and come delayed, then it's best to keep it open, because closed wounds are very popular among the bacteria, and it will cause infection. It's better to leave it open to drain. If it's a nice fresh wound, then you could actually approximate the wound edges, obviously not with under tension. You can suture it, and the wound will heal primarily fast. So that's what we can do for most wounds. Antibiotics seem to be a reflex thing. If there's contamination, yes, you're not treating infection, you're doing prophylaxis. So in addition to cleaning the wound, washing, removing debris, dead tissue, fragments, you can give a course of antibiotics for the bacteria that you don't see. Right. So that's a standard wound. Now I'm sure we are talking of complicated ones, where the healing process is defective, right? So when the healing process is defective, the wound will not heal. So that, I think, is the main focus of today's talk. But I think the bit that I said is also relevant in order to come to this point. Wounds that don't heal naturally. So what I told you initially about wound care is, what is wound care? Wound care is removing obstacles to healing and providing what the wound doesn't have to heal. If we can provide that, yes, then the wound will heal. So what are the factors, what are the reasons why wounds don't heal and they become chronic? become chronic. So what are the factors that are responsible for non-healing? Obviously, if there is bacteria which we cannot eliminate from the wound, there is going to be chronic bacterial injury and ongoing inflammation as a response to that, and the wound remains stuck in the inflammatory stage. There's ongoing injury from bacteria. Right? So how can that happen? Nobody's pouring bacteria into the wound every day. The bacteria that are there are not being eliminated, not being killed. So how do we get rid of bacteria usually? Never forget the importance of the white cells. The white blood cells are the frontline army that we have to protect us from bacteria. When these white cells don't do their job, the bacteria remain, proliferate, and in fact cause more damage. So the wound progresses under those circumstances. So why would the white cells fail is the next question. We are talking of people with white cells. We are not talking of people without cells. Those are people who have had immune suppression, so their white cells are low, or some bone marrow problem with very low white cells. You see how very quickly they die from streptococcal, staphylococcal infections. Within 24 hours, they could be dead. It's only then that we realize how important the white cells are, just like the clotting mechanisms. We can be surgeons, we rely heavily on a normal clotting mechanism to prevent our patients from bleeding at surgery or any trauma. Similarly, we rely on the white cells to do a hell of a lot of things. So white cells don't work if there is no oxygen. White cells require a huge amount of oxygen to do its job. And how does it get oxygen? It gets oxygen that is dissolved in the hemoglobin. And how does hemoglobin get to the site of injury? It comes through the arteries into the capillaries under high pressure. So if your circulation is poor, if the circulatory pressure is low, tissues don't have enough oxygen. Tissue oxygenation is vital for white cells to be functional. It has to move actively. It has to move out of the capillaries into the tissues. It has to swallow the bacteria, and it has to kill the bacteria. All these require huge amounts of oxygen, ATP, which is the energy that is required for all these things to happen. So oxygen is, never underestimate the requirement for oxygen. So even bits of dead tissue fragment which are hypoxic cannot kill bacteria, and the bacteria will remain in those dead tissue bits and proliferate. Now, what are the other tissues? So we are not talking of peripheral vascular disease as yet. We are talking of a wound that has ischemic parts. So one poorly vascularized bit of tissue that we have, all of us, is bone, tendons. These are poorly vascularized. You cut a tendon, you're not going to bleed. You cut a bone, you're not going to bleed. They're anyway poorly vascularized. So when bacteria get deposited in these tissues, which are anyway poorly vascularized, we are stuck. We can't kill the bacteria in these. The white cells don't get there. There is no oxygen in these tissues. The bacteria just hide there. Similarly, foreign material. Similarly, these implants that we put in, things that are not living, not vascularized, these bits cannot defend themselves from bacteria. Bacteria can hide. Even a suture material is a good hiding place for bacteria. So when there is bacteria hiding in these places and they multiply, the tissue injury is ongoing and the wound cannot progress towards healing. And you're stuck in an inflammatory situation. So many examples like sinuses, wound sinuses, small, but the wound doesn't close. It's very deep. And if you probe it, you hit bone. In the feet, you hit the bone. And if you hit bone, you can be sure that is the reason. There is dirty bone from which is a hiding place for bacteria. So until you remove that, the wound will not heal. So we need to know and remove all the hiding places for bacteria. So another reason why white cells don't do their job is high sugar, hyperglycemia. So even a diabetic who has never controlled him or herself, when they have a wound, it is important to manage their glycemia because the glucose metabolism, normal metabolism, is very important for the normal function of the white cell. So just imagine a diabetic even without peripheral vascular disease. You know that diabetics have, you know that diabetes is a vascular disease. It's a metabolic and a vascular disease. It causes a microangiopathy. Micro is arterioles and capillaries, and it causes a macroangiopathy as well. The macro is accelerated atherosclerosis with arterial wall calcification as well, medial calcification. And the microangiopathy is a microvascular dysfunction, which is a diffusion problem. It's not occluded. So whatever happens, there is some element of hypoxia, at least due to the microangiopathy, which we cannot fix. Then you have hyperglycemia. So are we surprised that we can't kill all the bacteria and progress to healing? Right. What else? What else? What are the other reasons why wounds don't heal? Repetitive trauma. Now, we spoke about repetitive bacterial injury. What about physical, mechanical trauma? What is it that protects us from injuries? It's pain. We have a natural protection from pain. Pain protects us way beyond what we can imagine. How do we know? Look at people who don't have pain sensation. In the old days, it was leprosy. Today it's diabetes neuropathy. Then you have people with spinal cord injuries, other nerve injuries, and they have amazing trauma because they have not been able to protect themselves. So they may be the primary cause of injury or what allows injury to happen. Easy wounding is what is happening there. They have easy wounding and faulty healing. Now, people who don't have pain sensation, if they get a wound on a weight-bearing surface, will they stop walking on the wound? No, they wouldn't. Most of them can't feel the wound. Most of them can't even see the wound. The wound only exists in the eyes of people who can look. These patients they are not even aware that they have a wound. So all they do is walk on the wound. And if you keep walking, weight bearing and walking on a wound, how is that wound going to heal? And usually these wounds are over pressure points. And we know that diabetics have pressure points because of the alteration in the structure of their feet. Structure is bones, joints, tendons, and muscles. All these are affected in diabetes. And even before a structural change is visible, there is functional change because of the muscle. The neuropathy affects muscles, and the weight bearing is abnormal with pressure points. So usually a wound in a pressure point keeps getting traumatized when the patient walks. So repetitive mechanical trauma is another reason why these people don't heal. They go on for months and months without healing. So we are identifying reasons why wounds don't heal. If we don't know the reasons, how can we fix it? This is why we are talking about this. We are there to fix the problems, remove obstacles to healing. Then the wound will heal. Right? So we have spoken of basically ischemia. Ischemia is one. Other one is repetitive injury. Other one is infection. Sometimes all three are there. And the fourth one is impaired immunity from hyperglycemia. So these are the four main factors that sabotage wound healing. Now, what is the other main reason why wounds become chronic and don't heal apart from diabetes and all the different the angiopathy and the neuropathy that makes diabetic wounds not heal? What is the other condition which gives rise to a lot of lower extremity ulcers?
Can we get some answers, please?
Diabetes causes foot ulcers. What causes leg ulcers?
Deficiency, varicose veins.
Yes. So we call it chronic venous insufficiency, right? So venous insufficiency. Venous insufficiency means stagnation of blood venous stagnation. We are all upright animals. We are walking upright. We stand upright, unlike other animals. So, the blood that gets pumped to the foot through the arterial system has to return to the heart. And that's not an easy business. That's difficult. So,
I think he was cut off again. Wait. Wait, I'll call him again.
can you hear me?
Sir, yeah, can hear, sir. Yeah, you're cut off.
So the blood, when there is venous stagnation, and I heard some people saying varicose veins. Yes, varicose veins are the manifest circulation. So there is chronic venous stasis, venous hypertension, and changes in the microcirculation and the tissues. Then again, it's due to chiefly hypoxia. There is hypoxia, white cell leakage, deposition of hemoglobin, hemosiderin. All these are very, all these are very toxic to the tissues. And that's the reason why there is spontaneous ulceration or even minor trauma causes a wound that rapidly enlarges because of the factors that I mentioned. So again, we are looking at reasons why wounds don't heal. It is the venous hypertension. And that can be due to superficial venous problems, deep venous problems, or a combination of the two. Which one is more severe? Which one is more wound producing? It is the deep venous insufficiency, because you know that deep veins drain most of the blood, not the superficial veins. So when there is superficial venous insufficiency, the effect is actually much less than when there is deep venous insufficiency. But most of the ulceration that we see is entirely due to superficial venous insufficiency, valvular incompetence, not thrombosis, not occlusions. So remember, one thing is to observe varicose veins. Next thing is varicose veins don't cause ulceration without prior skin changes. That is pigmentation and eczema, lipodermatosclerosis. All these things you don't have to remember, but if you see pigmentation and an ulcer, then you know this is venous insufficiency, even in the absence of visible varicose veins. And you know the typical site just above the medial malleolus. Right. Again, if there is concomitant arterial occlusive disease, a venous ulcer will get worse. It can cause more pain, and the ulcer can even get bigger, and it won't heal. So these are called mixed ulcers, venous and arterial. So you can have all kinds of combinations. So basically, coming back to assessing an ulcer, right? We are looking for reasons for non-healing and trying to fix these. So Is there ischemia? How do we know whether there is ischemia or not? Yes, we always remember we used to be told first history, examination, investigations. So most people start with investigations, and that's not very efficient. And investigations can be wrong. And investigations for peripheral arterial occlusive disease are usually wrong and very misleading. What is the investigation I'm referring to? Anybody?
Duplex.
Yes. People ask for duplex scans when they think of peripheral vascular disease. And you know, who does duplex scans? Radiologists. They have no idea, no clinical idea about what to even look for when they do scans. And usually you get a report which is useless, right? Which will always try to describe irrelevant arterial stenosis, because all what we need is to know whether you can feel a pulse in the foot, right? If we can feel a pulse in the foot, then duplex scan becomes irrelevant. There are two pulses, you know, dorsalis pedis. Sometimes you can feel the anterior tibial also above the ankle and the posterior tibia. If one of the two are present, we are generally okay, because they interconnect in the pedal arches and compensate for when one fails, the other one compensates. Okay? So, we need to be able to palpate pulses. If we can't feel it, then it's not there. It's not there. History. It's always interesting to find out whether the patient has had intermittent claudication. Of course, intermittent claudication will be there only if people walk sufficient distances. So people who don't walk, when they say no claudication, doesn't mean there is nothing, right? And some people claudicate, but they haven't taken serious note of it, and they will not report claudication. But if you can feel pulses, you're okay. If there are no pulses, now we are not looking for acute limb ischemia. As medical students, you would have been told, you know, when their arteries are blocked, how do we recognize them? There must be gangrene, right? The foot must be cold, right? The foot must be pale or cyanotic. There must be loss of motor function and loss of sensation. These are all features of acute limb ischemia. Now, we are not talking of acute limb ischemia. These are people with chronic limb ischemia. Chronic limb ischemia, the ischemia doesn't have to be so severe to cause pallor or cyanosis, doesn't have to be so severe to cause a low temperature, cold skin. It doesn't have to be severe to cause paralysis. It doesn't have to be severe enough to cause sensory loss or paresthesia. It's just, I mean, you can't distinguish from a normally perfused foot. The problem is when there is an injury, if there is some trauma, then even mild ischemia can become a huge problem, because fighting infection and healing requires an optimum oxygen and circulation. Anything suboptimal will start a huge problem. So perfectly normal looking feet with nail problems. We very commonly see doctors removing nails that are, when there's paronychia, when there's infection, they remove the nail. And that becomes the beginning of the end of the toe. The trauma from nail removal, the nail bed goes black. And this gangrene then spreads because of spreading arterial thrombosis. The microcirculation, the small vessels start to thrombose. So remember, these feet look perfectly normal. Just that, how do you know? The pulse is absent. Right. So
there are some questions.
Yeah.
Shall we?
Yeah, we'll deal with some of the questions.
Yeah. The first question is, there is a big difference between acute wound and a chronic wound. Can you explain a bit?
Yeah. So that is what I started off with. All chronic wounds start with an acute phase, right? And acute wounds usually heal in normal people. I think was my initial explanation of the healing process, and that it will all heal despite what we do. But when there is a problem towards healing, the acute wound doesn't heal, and what is not acute and still remaining is a chronic wound. And we've been talking about reasons why the wound hasn't healed or why has it become chronic. And we mentioned oxygen, ischemia, repetitive trauma, infection, and hyperglycemia-induced immune problems, which sabotage the white cells, as the key reasons for non-healing. And these are all seen in diabetic feet. And then we have chronic venous insufficiency also, one of the very common reasons for leg ulcers. And these conditions prevent healing of acute wounds, and they present with chronic non-healing wounds.
Yeah, so we have we have discussed that in length.
Yeah.
So the next question is fresh wounds. Example, multiple abrasions after RTA. How frequently it should be dressed? It's a very practical question.
Yeah. So if it's an abrasion, right? Abrasion
The default is EOD, no?
Yes. Yeah, I think that's totally inappropriate, excessive. I don't think we can afford to do that. I think all you need to do is to wash it thoroughly and put a non-adherent, I'm talking an abrasion, right? Abrasion, put something that doesn't stick. You need to cover it because people don't like to keep wounds open. And more than preventing it from getting contaminated with bacteria, put a non-adherent dressing, and a very cheap, easily available non-adherent dressing is a bit of Vaseline gauze, right? And so you don't need to keep looking at this wound, right? Because once you have washed it, and you can give some, particularly people with diabetes, people with problems, you would give some prophylaxis, antibiotic prophylaxis if you're worried. I don't even do that sometimes, but just wash it. If it's not deep, if it's only an abrasion, you're not going to be worried about it, right? And you can always tell a patient to come back if there is increasing pain or fever, because every other day you're going to see some inflammation anyway from the trauma. And what you need to do is to give some paracetamol for pain. If you want to give antibiotics, okay. And you can have a look at the wound after about 5 days, 7 days, and try not to traumatize the wound by pulling off an adherent dressing. Best left alone. If it's an open wound, a laceration, which you haven't sutured, then depends on what you put on the wound. Now, if you put a moist dressing, I think most of you will have access to saline. What else do you all put? Povidone iodine. Now, povidone iodine is a very expensive, useless solution, because when it comes into contact with biological tissue, the iodine is ineffective. So what you have is just water. So povidone iodine is useful to clean up skin before we make surgical incisions. It kills bacteria on the skin surface, but there's no purpose in putting povidone iodine solution into wounds, inside wounds. It has only irrigation effect. So for irrigation effect, you can use water, running water, or saline, both of which are freely available, cheap, and as effective than the more expensive povidone iodine. So for a wound, you need a moist environment for healing. So that's why we put moist dressings. But all these moist dressings tend to dry up within the same day. And that's the reason why we use some gels. Now, what are the gels that are commonly used? We used to use Metrogel, because the only reason, all we need is a gel, but Metrogel was the cheapest. Metronidazole was not necessary. It happened to be part of the gel. Hydrocolloid gel is probably the best. But the hydrocolloid gel brands we had were all imported, very expensive stuff. Have you all used hydrocolloid gel? What were the brands? They were called Intrasite, Purilon gels. These were several thousand rupees for about 30 grams. But fortunately now there is a local hydrocolloid gel, which is cheaper than the Metrogel. So you can imagine how the imported hydrocolloid is so expensive when it actually can be manufactured for much less locally. So we are using a lot of hydrocolloid gel when we want moist surfaces over a few days. So we don't need, if we put a hydrocolloid gel, we don't need to have a look at it every other day, right? Again, we can see it in about 5 or 7 days. Now, fear of infection is the reason why I understand most medical officers want to take a peep at the wound. I mean, they look at wounds, even that those are sutured wounds. So all we need to do is, we need to clean the wound thoroughly and dress. And you can get the patient to come back in 5 days. And you don't need to do it every other day. Every other day means it's a lot of dressings wasted and human resource to change the dressings.
Exactly.
Sir, I have a question.
Go on, yes.
Yeah, sir, as per your lecture that if you don't use povidone iodine as a material to dress the wound, what is the other solutions that we can use in government sector?
The saline.
So saline alone will do the work, sir?
Yeah, povidone iodine in the wound is saline.
Right. Okay.
I mean, iodine doesn't work. Iodine iodine is inactivated in the presence
Right.
of
Okay.
biological when it comes into comes into contact with raw surfaces.
Yeah.
Iodine is effective on intact skin.
Right. Okay.
So you're only cleaning if you want to clean the neighboring skin. You can use povidone iodine.
Right.
All right. I mean, just to put you in the picture, it is not even recommend now when you catheterize, when you do urinary catheterization,
Yeah.
right? We use a lot of povidone iodine to clean the scrotum and the penis and the whole thing, right?
Yeah.
Yeah. Now, studies have shown that it's a waste of povidone iodine. All you need to do is to wash with saline.
Right. Okay.
There is no advantage in using povidone iodine, even in those circumstances. So you can put a moist dressing that is saline, but the problem with all moist dressings is it dries up very quickly, right? So that is one of the reasons why we use moist dressings when on patients who are in hospital, because they are in hospital.
Yeah.
But you don't keep a patient in hospital just because you need to change the dressing every day.
Yeah.
If we can delay the dressing change, then you can send them home.
Mm.
So this is where a gel is better, right?
Yeah.
When there is an exudating wound, then you use other material like polyurethanes and stuff, right? Then there are the hydrocolloid sheets, which
Mm.
are extremely good in maintaining moisture, sometimes too much moisture. So it's all a bit business of maintaining a moist environment. Now, Vaseline gauze also preserves some moisture and prevents the wound surface getting adherent to the dressing.
Okay.
Right. So now for dirty wounds, dirty chronic wounds, I don't know, I use a lot of acetic acid, which kills all bacteria, or Milton solution, that is hypochlorite, sodium hypochlorite, which is all of these are dirt cheap, freely available. Government hospitals, we get patients to buy if they don't, the hospital doesn't have. It costs very little, really. Right?
Okay.
So you can ask people to buy it. As long as you don't sell it, you'd be okay. You don't go to sell the solution. Even if you sell it at the price in the pharmacy, you'll be okay, don't worry. The problem is when you try to say there is a magic solution which costs 10 times of what is in the pharmacy, then of course you get into trouble.
Referring to the recent incidents, no?
Yeah.
So there are some other questions. Happy to take any more. Is anybody willing to share something that they have encountered, or any other questions? There are a lot of questions in the chat box.
Right.
Anyone has a question? So one has asked, does pyoderma gangrenosum need skin grafts in management to close the wound? If it's a large wound, or managing medically with immunosuppressants to control the immune dysregulation is enough?
Yeah. The problem with skin grafts that we see is a lot of skin grafts. Most wounds never look clean enough for a skin graft, right? But they still heal. So that is one situation. So you'll end up treating.
Is there anything special to the pyoderma, sir?
No, even pyoderma. I mean, if it's If it's very clean, then you can put a skin graft. But
Yeah,
otherwise,
yeah.
patients don't like skin graft because you have to harvest skin, and they are very worried, quite correctly, that that wound also takes time to heal. So most of the time, once you have practiced the principles of local wound care and immune suppression, the blood sugar control, the wound will heal. Eventually, it will contract.
So, anyone has any other question that now before going into another question in the chat box, we would like to get another question from the audience.
Has anybody asked about how to offload?
No, sir.
Yeah. So most of them don't know that they don't know how to offload. That's the
Yeah.
problem. So we see tons of wounds, silly wounds that never heal, simply because patients continue to weight bear on the wound. Now, how do we take the weight off the wound? So it can be the perfectly clean wound, well vascularized, but the wound doesn't, so it's not infected. There's no ischemia, but they keep walking on the wound. So you need to offload. Now, you need to offload to heal it, and you need to maintain offloading to prevent it from coming back. So how do we offload? If you just dressing it, you can't tell people to live in bed to heal the wound. It's not practical. People need to get around, move. So that what we do is so everybody knows that to offload, you probably need to have the right footwear. Now the problem with footwear are two things. One thing is you don't have the footwear immediately. The right footwear, the footwear that will prevent the wound from bearing weight. Secondly, the best offloading footwear, once the people go home, they don't wear it. Sri Lankans don't wear anything at home. We are barefoot. And you know that most of your life, all these patients, they spend walking inside their homes. So they keep the shoe separately and they don't use it. So non-compliance is very common. So therefore, we use a dressing. With the dressing, we offload the wound. That works because it kind of limits them from walking to some extent, but they all need to walk inside their house, go walk to the toilet, and so on. We offload with a dressing. We make a bit of a bund or a hump. So when they walk, the weight is taken off. We do it with bandages or gauze towels. So the wound is kept off the ground when the patient is standing and walking. Off the ground, above the ground. And so protects it from bearing weight, repetitive trauma resulting in non-healing. Remember about wound care, the most important thing about wound care is not replacing one dressing with another dressing. It's the assessment. Every time you see the wound, you need to assess the wound. What do you assess for? The same thing over and over and over again. For weight bearing on the wound, for ischemia, and for infection. You need to keep checking it all the time. Infection, is there cellulitis? Then you need antibiotics. If there is no cellulitis, there is no purpose in giving antibiotics. Unless the wound is really dirty, with a lot of exudate, lot of offensive discharge, lot of volume of exudate, the main line of attack is local antimicrobials, local, not antibiotics. But very important to check the temperature on the skin. Compare with the opposite side. If the temperature is high, then there is a necessity for antibiotics. So wound assessment is very important. It's not just changing dressings. So this is the whole problem about getting a nurse to change dressings. Because nurses, unless they are very good and trained, they don't assess the wound. They just take the dirty dressing off and put a fresh dressing. So there must be lots of other questions.
Yes, sir. Yeah. One has asked, some people use aloe vera on top of the wound to cure them. That's, I mean, I'm just going to drop it because we have already answered that with the use of gel, the importance of using a gel to prevent drying.
Yeah.
So, are there any early signs that may show a wound is transitioning from acute to chronic? That's, I mean, that also I think Prof has explained a lot now. I'm just going to drop it also. Following a burn injury, it is common to see blister formation. Is it advisable to rupture these blisters in the management before dressing?
Yeah. Just rupture, because the blister is useless and the fluid accumulation will extend the blister as the pressure increases. So it's basically dead skin. You can remove that skin and protect the underlying surface, and it will heal.
There's another question, sir. For the clean wound management, such as routine surgeries, we do not need antibiotics theoretically, but in our setup, it can easily be infected. So, do we need to give antibiotics in managing clean wounds? That's a very interesting question, I think.
Yeah, you know, that is basically we are treating ourselves. So the clean wounds, there are two types of clean wounds. Clean wounds, clean high-risk wounds. High-risk wounds are clean wounds where we put mesh and prosthesis, artificial material, where any bacteria can be quite dangerous, right? So those wounds we give prophylactic antibiotic prophylaxis. Now prophylaxis again is not 5 days, not therapeutic, right? Prophylactic antibiotic, basically 1 dose of antibiotics at least half an hour before the incision. You don't need to keep continuing antibiotic prophylaxis. Other wounds, clean wounds, mastectomies, thyroidectomies, what else? Varicose vein surgery, rarely done, but it's a clean operation. What are the other operations? Removing a sebaceous cyst, a lipoma. All these are clean operations. You don't need to give any antibiotics.
Yeah.
If you do these operations in operating theaters.
The following question is rather more interesting. Some use IV antibiotics to wash wounds. Does it work, sir?
I don't think there is no, I don't know why people use it, because there is no evidence.
I have actually seen they do a culture, and I mean, it's a clean wound, it's a colonized wound. Do a culture and wash with meropenem, teicoplanin. Recently, I got a patient who was been washed with colistin.
Yeah, I mean, these are mad. These people are simply crazy. Several points about antibiotics washing. First thing is, you want to kill the bacteria, right, on the wound, right? If you want to kill the bacteria on the wound surface, using acetic acid or hypochlorite solution, Milton, they are far more toxic, bactericidal than any antibiotic, right? Those kill bacteria more than any antibiotic. So if you want to kill bacteria, then that's what you should use. If there is necrotic material, you have to remove it. You cannot expect antibiotics or local antimicrobials to sort out dead tissue. You need to remove it. So that's a very important thing in wound care. Now, removing dead tissue, you need to do a sharp, either scissor or scalpel excision. Wound cleaning is not, you see lots of nurses, doctors, they take a bit of gauze and rub on the clean wound surface, right? That causes pain, and it doesn't really, if you want to remove something, remove it. You don't rub it off. So what doesn't get rubbed off, you have to cut. If you can't cut, then you have to use a hydrocolloid so that it gets so moisturized that it becomes soft and easy to remove the next time around. All right. So putting antibiotics work in tissues with bacteria. So antibiotics have to be swallowed or injected so that they come through the bloodstream. The concentration in tissues will kill bacteria in tissues. To kill the bacteria on the wound surface, you need to put toxic material directly onto the wound. So that is one thing. Next thing is this, we forgot to address this culture ABST business. Now, you culture any wound, you will grow bacteria, right? If you take a skin swab, you will grow bacteria. We don't live in a sterile environment. Now, what we want to do is to actually kill bacteria that is delaying or making the wound worse, right? So the whole purpose of doing antibiotic sensitivity is for a wound that is causing a cellulitis, because we want to give systemic antibiotics. Systemic antibiotics, the right antibiotic, we need to know what the bacteria is and the antibiotic sensitivity. Just doing wound swabs in the absence of cellulitis is a meaningless job, because you don't need to give antibiotics. And you don't do ABST to decide which antibiotic you should apply on the wound. Nowhere in medicine is these antibiotics, systemic antibiotics, used on wounds. Now we use fusidic acid, mupirocin, on surfaces with staphylococcus, usually staph. So these are not antibiotics we usually take IV or orally. These are for local effect, and there are few that are in use, the ones that I mentioned. Washing with parenteral antibiotics is a waste of money, and I think it's absolutely useless.
That's a relevant, related question. Like most of doctors are using fusidic acid and soframycin for fresh wounds. Is it effective?
I would say, I mean, it's okay, because you have contamination with stuff. So if you have washed it, cleaned it thoroughly, and you put some for whatever residual stuff. These local stuff should be okay, Tusita. It's
Yeah.
okay.
And
You really don't need to give it. You don't give. There's no point in putting those and giving oral antibiotics as well.
Yeah.
Yeah.
So another one is, what is the benefit of using dressings like betadine, acetic acid, and 3% saline alternatively? It's asking about
Yeah.
rotational dressings.
Yeah, rotational dressings. So we use acetic acid, hypertonic saline, hypochlorite solution in rotation, because we believe, I mean, some bacteria get killed with certain solutions. So the leftovers are killed the next time round with the solution. So you don't use, if you use the same solution, you kill the same bacteria. But the ones that don't get killed will remain. But the fact is that if you use acetic acid hypochlorite, it kills everything. I mean, you don't really need to rotate. You know that acetic acid is very good for Pseudomonas, which is one of the common bacteria that delay healing.
Yeah. So another question. I mean, what Sanjeeva Gunaratna here, what he has asked is where to use intrasite gel. I think that you have already answered.
Yeah.
Now I'm just pointing out the use of the product called intrasite gel. Now people people who promote it, they say there are so many things that are promoting wound healing in intrasite gel and all that. So is that, I mean, it's what do you think about it? Should we use intrasite gel or another, different thick gel, or is it just a thick gel, whatever is available?
Yeah, I mean, intrasite is a hydrocolloid gel which retains a lot of moisture over a longer period. You just need a very, very thin 1 millimeter, 2 millimeter thickness intrasite gel on the wound surface, right? So intrasite is just the brand name. It's a hydrocolloid gel. So we didn't have alternative to intrasite until recently, when now we have locally manufactured hydrocolloid gel, which is cheaper than Metrogel, or it's at about the same price as Metrogel.
Yeah.
So that is why we use hydrocolloid gel, which is not intrasite, because it's a lot more expensive than the locally manufactured hydrocolloid gel. Hydrocolloid gel is hydrocolloid gel. I mean, you don't need to. There is no other magic in intrasite. It's just a gel.
Yeah. So one is asking, is there use of penicillin for long period as a prophylactic agent?
Yes.
I think yes.
Yeah, repeated streptococcal lymphangitis, chronic lymphedema. If it's repeated, lifelong penicillin.
So
it's a harmless drug.
Yeah, there's another interesting question, sir. So, what is the best dressing for venous ulcer? Do it need antibiotic always? Let's take it separately. What is the best dressing for venous ulcers? What's the best dressing for any ulcer?
Yeah.
Is there a best dressing at all? How do you decide on a best dressing?
Yeah, I mean, the best dressing is a dressing that doesn't upset the wound, doesn't irritate the wound, doesn't stick to the wound, preserves moisture. It acts as a barrier to the outside world. It absorbs and retains moisture, too much moisture. It doesn't allow it to dry. It doesn't allow it to be too moist, because it macerates the skin. And something which is easily accepted, not allergic, easily available, cheap. So those are the ideal wound dressings. So depending on the wound, depending on how much exudate, how moist the wound is, we use different dressings. If the wound tends to be dry, then we use hydrocolloid gel. If it's exudating a lot of juice, then we use polyurethane foams. We use a lot of gauze so that it retains the wound exudate. Then we have local antimicrobial incorporated dressings. So the two popular antimicrobials for local action, that is not povidone iodine. You have iodosorb, which is what is it? What is the material? The real name? It's a different iodine preparation. Different preparation because iodine is antimicrobial. Iodine. It is available for local wound care. Then you have silver, ionic silver, nano silver. Silver works